Good afternoon, everybody. So we're running out of short of time, so let me wind up and cover the most critical aspects. So there are various IOL related procedures, corneal procedures which are available. Today I will be talking to you about one is the supplementary IOLs. The other thing is the supplementary phakic IOLs for the refractive surprise. The rule of thumb is preferably we follow the rule of twos. That is, before doing any refractive surprise correction, at least you should wait for 2 months, preferably 3 months, and 2 refractions should be stable and at 2 consecutive visits. But before jumping on to any other procedures, we should know some other things which can be corrected by simple things. For example, if you have placed a toric IOL, there is a misalignment, just dialing a toric IOL will correct a refractive surprise. Sometimes you might have put an IOL inverted upside down, just see that and correct that procedure. So our simple PCO, posterior capsular opacification, could have caused a mild lens tilt and other things. Those things can be corrected very easily. We think of IOL options only when it is beyond outside the limits of the LASIK, could be due to the higher refractive errors or due to the thin corneas. We call them as a duet procedures. Either it could be primary duet procedure or a secondary duet procedure. Secondary is the one which we will be commonly doing for the pseudophakic refractive surprise. So which are the ideal indications for supplementary IOLs? One, as we told, pseudophakic refractive surprise, that is a post-surgical ametropia, enhancement of near or far vision post-cataract surgery, residual corneal astigmatism. In pediatric patients also, suppose if you want to convert monovision into a multifocal or other way around also it can be done. Whenever IOL exchange is difficult, either due to capsular fibrosis, zonular dehiscence or a PC rent, you can go for a supplementary IOL. The interesting thing is, since these are large optic IOLs, you can consider these IOLs for the negative dysphotopsia also. So which are the contraindications? What are the contraindications for putting these supplementary IOLs? One is somebody who has got a pigment disposition syndrome, loose zonules, capsular tension ring, which if it has been used for the primary implantation, if there is a posterior synechia to the capsular bag, or significantly reduced corneal endothelial count, preferably you should avoid these things. Why supplementary IOLs? Why not the conventional piggyback IOLs, that is putting 2 biconvex IOLs together? Because that leads to one significant complication which is known as interlenticular opacification. Because there is a opacification which develops between the 2 IOL surface which hampers the vision. And sometimes the other complications related to cataract surgery can also occur, but the main complication is interlenticular opacification. But before jumping on to doing supplementary IOLs, please dilate the patient thoroughly and evaluate him under slit lamp or any other imaging modality. For example, the Sommering ring which is seen after dilatation may be confined to one localized segment and it may cause the tilting of the IOL. So that's the reasons you may have a problem with that. If you can image the zonules with any imaging modality, that's the best part of it, because in an undilated pupil, if the zonules are weak, preferable to avoid a supplementary IOL. What are the preoperative essential parameters you require to place these supplementary IOLs is, one, you should know the manifest refraction, that is pseudophakic residual refraction, the axial length, current keratometry, pseudophakic anterior chamber depth, target refraction you are aiming for, A constant of the piggyback IOL, that is a supplementary IOL which you are using, initial power of the IOL from the records if it is available, it's an essential thing. There are various nomograms which are available, which we can, all you require is to assess whether it is a myopic residual refractive error or an hyperopic, and look for the spherical equivalent and multiply by the constant parameters which are given by the nomograms, so you can correct most of the refractive errors. Similarly, this is another nomogram which one can follow. What is an ideal supplementary IOL? One thing is you should place them in the sulcus, they should not rotate, they should not touch the primary IOLs, there should not be any pupillary capture or an iris capture, there should not be any pigment dispersion. For these reasons, we tend to use a very large diameter IOLs. These are in the range of around 14 millimeters. They have got a very large optic of around 6 to 6.5 mm, so there is a less risk of optic capture and other things. And the surface is so angulated, aptic surface and all, there is a less risk of pigment dispersion. And the configuration is such that these are all anterior convex and posterior concave. So there is a clear-cut space between the primary IOL and the sulcoflex IOL. There are various ranges which are available. If you want to correct a spherical, you can use aspheric. If you want astigmatism, toric, even multifocal toric are available. Recently, they have introduced the trifocal sulcoflex IOLs or a sulcus placement IOL. There are various, I don't have any financial interest, there are various supplementary IOLs are available. 2 key things one should remember while placing a supplementary IOL is, make sure that you well form the sulcus before implanting a supplementary IOL. The second thing is, try to keep the orientation of the aptics at least 90 degree to the aptics of the primary thing. And these studies also proves that the centration is quite good with these IOLs, even the rotational stability is quite good. There's an interesting lens which is available for as a supplementary purpose. If somebody has got a very irregular astigmatism, you can use these lenses known as the extra focus pinhole lenses. These are black lenses and these are infrared radiance lenses. Suppose if these can be put in patients with who have lost the iris tissue and has got a irregular astigmatism secondary to keratoplasty or severe keratoconus, and so those patients, you can use this. The only thing is you may have to use an infrared light to assess the posterior segment details, because it is a black IOL, you will not be able to see the posterior segment details. So very irregular astigmatism, you can consider this. So how to calculate the IOL power for these IOLs is, the ready-made softwares are available. One such is, if you want to put a lens from an Rainer, there is a ray trace which is commercially available. You have to just feed the data, anterior-chamber depth, keratometry and other things and all. It gives a ready-made estimated target refraction IOL which has to be implanted in the sulcus. Here is a patient who has undergone a keratoconus patient who has undergone a cataract surgery. Definitely he was not improving with glasses or anything. He had a 20 by 200 vision. With a toric sulcoflex lens, he has improved up to the 6 by 12 or 20 by 50 vision. So let me show you a small video of a toric sulcoflex. You mark the corneal markings as a way you mark for the toric IOLs. The clear corneal incision will be made, and it is then it is injected like any foldable IOL. It is placed in the sulcus and it is rotated into the axis of a concerned axis which you have marked. Usually iridotomy is not required in these cases unless it is a compromised anterior chamber depth or you feel that there is a crowded angle. So you can do a peripheral iridotomy. Otherwise, surgical iridectomy or peripheral iridotomy is not required. They don't usually cause pupillary block or a secondary glaucoma. So implantation is very simple. The only thing is the assessment and the surgical procedure is simple. The choosing the right IOL and the procedure is very, very important. Once you implant it, you can rotate it to the concerned axis which you planned for. So align it to the axis which you have marked for, and that's it. If you want, you can, after removing the viscoelastic, you can use the pilocarpine also. Recheck the axis which you have implanted and go ahead with the surgical procedure. Another commercially available thing is the add-on lenses. These are the 4 footplate aptic lenses similar to the Rainer lenses. They can be implanted. The rotational stability is also, they usually don't rotate well. They get the 4 aptics gets fixed in the sulcus area. So the implantation is quite simple. The only thing is it has to be done in a proper way. That's the thing. And make sure that you remove all the viscoelastic between the 2 IOL surfaces. The interface has to be cleared very properly so that sometimes a membrane can form. You can, suppose somebody's cornea is thin and if you don't fit into corneal procedure, you can plan for an ICL also. Pseudophakic patient, you can do an ICL over the pseudophakia. And similar to that, the implantation is quite simple. Only thing is evaluation is very critical here. Post-op, you can see by the imaging modalities, there is a clear-cut space between the ICL and the primary IOL. Whether to do a PI, suppose if you plan a PI, sometimes you end up with complications in some other cases. Like this, after doing a PI, there was a minimal ifema. You wash the ifema and even then the residual ifema persists. You feel that it will clear in the post-operative period. Of course it clears. But if you look in the post-operative period, there is a membrane develops in the interlenticular area because of the ifema. So this needs to be washed off in the post-operative period because it's a fibrinous membrane and may not clear spontaneously. And beware of the things like you may place the sulcoflex IOL or a supplementary IOL upside down. So one should know the correct orientation of the IOLs. It should always be convex anterior and concave posterior. It should not be other way around. So it is a very safe procedure. Long-term results are excellent. The main advantage is it's a reversible procedure. No IOL power, the thing is no complications compared to the IOL exchange and all. Supplementary IOLs can even be planned in pediatric patients also. Thank you.